Greetings. My name is Dr. Robert Gish. I'm based in San Diego, California, USA. I am a medical hepatologist, but very involved in managing liver cancer patients, liver transplant patients, adults across Nevada, California specifically, but I'm very involved globally and very involved in Vietnam over the last 20 years. And it's been an honor and a pleasure to work not just with VVHA, but to work with all my wonderful colleagues in Vietnam and really learn a lot of medicine when I'm there. You teach me a lot. Thank you. This presentation will be on new therapeutics for advanced liver cancer. This is unresectable liver cancer. And the medicines I'll be discussing today are available in developing, or what we now call, low and middle income countries. Which is good news. Many, if not most countries, have access to one, if not 5 or 6 of these different medications. My disclosures are on this slide. Go to my website for all information. Here we have a list of first line and second line or third line or later line HCC treatments. Again, unresectable HCC. First line at this time is a combination of atezolizumab and bevacizumab. Sorafenib, which has been available now for almost 14 years, is still co-first line oral as opposed to IV for what I'm going to call for this conference AV therapy, and lenvatinib, which has a non-inferior study, also an oral agent compared to sorafenib. Second line therapy is regorafenib, that is available, and Pembro, available 2019, an intravenous medication. There are other medications in this space as well, including cabozantinib, which we need to keep in mind, and ramucirumab, but these have limited access in developing countries. The accessibility is that these 5 drugs, actually 6, are available in Vietnam in hospitals, key hospitals, oncology centers, and some retail pharmacies. There are out-of-pocket and reimbursement expenses, but availability is there. There are discounts. There are some funds to pay for part of this, depending on the hospital, the center, the company, and the medication, and other indications are listed below. I really like this graph, but I'm not going to go into all the details here because it probably would take 10 minutes to really discuss this slide. But I want your eyes to go to is the second column from the right, where it's advanced stage C, BCLCC, with portal vein invasion, maybe lymph nodes, maybe metastatic disease. It's advanced stage unresectable for candidates for these different first, second, and third line therapies. A little bit more detail listed below. I didn't mention nivolumab, but that's also available. And these medications, especially these checkpoint inhibitors that we've been talking about, including ipilimumab, are typically used now in combination, just like what we call AV therapy. But look at these incredible survivals, right? With AV therapy, we have a median survival of 20 months. This is an amazing advance. Thinking about when sorafenib therapy came out, we were encouraged by anything with a median survival over 6 months. Very, very fascinating. But remember, stage your patients, talk about their performance score, do a Child's view, do a MELD score, have excellent imaging, may need a chest CT, may need a bone scan to stage your patients. Another complicated graph, but I really want to highlight here is in the upper right-hand corner, all of these first and second or subsequent line therapies are recommended and have a strong recommendation, strong positive based on advanced, especially phase 3, large randomized trials. The only thing I don't agree with on this is radiation therapy Y90, which even though the level of evidence is high, this group, this specialty group that organized a meeting and advisory board said that this is not recommended or strong negative. And I strongly disagree with that, although Y90 is costly and requires a lot of technicalities to have this administered. This is an angiogenic tumor, so we really want to block VEGF if we can. Unfortunately, a lot of the TKIs, the oral agents that we talked about, do block downstream signaling from VEGF. And there's multiple VEGF receptors, as you know. And of course, we directly attack the VEGF receptors with these monoclonals. That also worked very, very well. This angiogenic signaling modulates oxygen nutrient delivery and actually modulates immune activity. And with all the new medications, first-line medications, by modulating the immune system, by enhancing the immune system, de-repressing the immune system, we're doubling our median survivals. The tumors are self-maintaining. They are secreting factors that cause systemic immune suppression. Immune checkpoint inhibitors, this is part of this first-line therapy. We have PD-1, PD-L1 therapies. Those are listed on the left, including nivolumab, pembrolizumab, durvalumab, atezolizumab also should be listed on this slide on the left side. CTLA-4 listed on the right, also part of this checkpoint system. Tremelimumab's in advanced phase 3 studies. Ipilimumab has finished at least phase 2 and is in phase 3. And we'll have a lot more details on these to further enhance the immune system and even use CTLA-4 with PD-1 and PD-L1. We're already doing that, but unfortunately there's higher side effects, but maybe higher response rates. So the trade-off may be worth that as you balance risk and benefit. So we also see another opportunity about synergism between IO, these immuno-oncology drugs, and these dirty kinases, these tyrosine kinase or multi-kinase inhibitors. So what's going to happen very soon is all of our patients are going to be treated with combination therapy. First line, second, and subsequent line. It's going to be a lot of mixing and matching. Of course, that will be mostly evidence-based. Nivolumab, another first-line therapy, showed to be non-inferior to sorafenib. This is an overall survival graph. But look on the right side. Look at that box that says response rate. Response rate combines this complete, partial, and stable disease and brings these data together. But this response rate overall is 41% lenvatinib versus 12% in sorafenib. Now, sometimes progression-free survival or tumor response rate does not equal a major change in median overall survival because it's key to manage the underlying liver disease. Treat the hepatitis B, cure the hepatitis C, treat the NASH, MAFLD, very, very important, and have patients stop alcohol intake. Regorafenib, second-line therapy. This is in patients who are sorafenib failures, but sorafenib tolerant compared to placebo, had an improvement in overall survival as second line. This REACH study was very important with ramucirumab, which is now targeted for patients with alpha-fetoproteins greater than 400 as a second-line therapy. This is a VEGF inhibitor administered intravenously. It does have superior overall survival. Pembro, another drug that's in that checkpoint inhibitor classification that we were talking about, had a survival follow-up. Objective response rate here using RECIST was in this study. And then secondary endpoints were duration of response, disease control rate, overall survival, time to progression. And in this study, they did show excellent progression-free survival, but more importantly, median overall survival that's now up to 13 months. And this allowed this drug to be approved by the US FDA off phase 2 data. This is data on nivolumab and what's called the Checkmate 459, nivolumab versus sorafenib. Also a phase 2 study that led to a phase 3 study. In the phase 2, there was superiority. In the phase 3, it did not reach statistical significance, even though there was about a 2-month difference in median overall survival. Nivolumab still remains approved for HCC, even though it did not meet this phase 3 primary endpoint of overall survival statistical significance. But the FDA, in their wisdom, knew that nivolumab would be continuing going forward in combination therapy with other drugs, including TKI inhibitors, multi-kinase inhibitors. Single agent immunotherapy, this is a second-line Pembro showing this primary endpoint of overall survival. Now we have 13.9 months versus placebo at 10.6. P-value 0.02, phase 3. Now it's interesting, this p-value did not reach the predetermined statistical significance that the company agreed to with the FDA, yet it's statistically and clinically significant to us clinicians And Pembro remains on the market, even though it didn't meet its phase 3 primary endpoint. So combining therapies, I mentioned, is really the future, and that's what you need to keep your eye on. Combining a CTLA-4 or a PD-1 or PD-L1 with a tyrosine kinase inhibitor, multi-kinase inhibitor, a VEGF inhibitor, including potentially ramucirumab. Also, these TKIs, very importantly, there's really good data on cabozantinib, actually, and some on lenvatinib that directly modulate the immune system as well. Very nice graph here about atezolizumab and its interaction with T cells, bevacizumab, a VEGF inhibitor, having to change T cell infiltration, changing activity of immunosuppressive cells such as Tregs. Very interesting that VEGF inhibitors are actually immune-enhancing medications. This is looking at overall or objective response rate, atezo-bev 30% versus 11% for sorafenib. So this is amazing data. Ongoing response, 54% versus 5%. This drug combination really changed the world. As we get close to wrap up here, just want to keep in mind there's all these different combination studies that are going on. We have a large number of liver cancer patients. It's great that they're wanting to be involved with these clinical trials. The only thing that's I'd say interesting on here is a therapeutic vaccine, a Pexavac vaccine that's also being looked at as well. This is a little bit more on combo with lenvatinib and Pembro. Lenvatinib has a lot of interesting activities that appear to be sort of, I would say, another phase above drugs such as sorafenib or regorafenib. And of course, they decided to model this with a checkpoint inhibitor. And we're looking at very, very interesting. Look at this median overall survival. Again, it's not head to head, but this is again about 2 months better than the AD therapy that we were talking about. And then progression-free survival also was very substantial at this 8-month interval. Remember, finally, that we have potential off-target effects, especially from the checkpoint inhibitor drugs that are there. We know from the oral TKIs, we have gastro effects, fatigue, skin effects, thyroid, renal, they can all take place, including bleeding. But these autoimmune events can take place in these, the checkpoint family need to be monitored, and all your patients, you do need to be a hepato-onco-immunologist. Conclusions and takeaways. Let's think about this for a moment. First off, the side effects we were just talking about are relatively rare. In the 2 to 9% range, much higher if you're using a checkpoint inhibitor in the PD class with a CTLA-4 together. Even though you may have better response rates, you also have higher risk that needs to be balanced, benefit versus risk. We want to minimize liver injury as we're monitoring our patients, treat the underlying liver disease, monitor for adverse events that could be from the drugs, directly as liver toxic, could be from the medications with immune enhancement, and it could be viral B or C reactivation, which fortunately is relatively rare in this setting. Thank you very much to the VVHA group, the best for you at this wonderful meeting. And if there's Q&A, I'm available, including by email or through my website. Thank you so much.